Good day, everyone. I am Yachasana Singh, and I will be presenting on cerebrospinal fluid diversion procedures. So, a little overview of the ventricular system anatomy will be done briefly at the beginning of the presentation, followed by description of the many different shunts that can be used and diversion procedures. Cerebrospinal fluid diversion procedures aim to redirect the CSF flow to alleviate symptoms and complications associated with increased intracranial pressure. Cerebrospinal fluid is an ultrafiltrate of plasma and is produced by specialized epidermal cells of the choroid plexus within the ventricular system. The ventricles are responsible for the production, transport, and removal of cerebrospinal fluid and is derived from the lumen of the neural tube. It serves three main functions, which are protection, buoyancy by immersing the cerebrospinal fluid by being immersed in CSF. The net weight is reduced and this prevents excessive pressure on the brain. And CSF also serves as chemical stability in terms of maintaining a low extracellular potassium for synaptic transmission. The ventricular system is made up of 4 ventricles that include 2 lateral ventricles, one in each hemisphere, the 3rd ventricle in the diencephalon, and the 4th ventricle in the hindbrain, which continues inferiorly with the spinal cord. A little bit more into the lateral ventricles. They are located within their respective hemispheres of the cerebrum and have horns, as you can see in the image here, which project into the frontal, occipital, and the temporal lobes. The volume of the lateral ventricle of note increases with age. The 3rd ventricle is connected to the lateral ventricles by the foramen of Monro, as seen in this picture. And the 3rd ventricle is situated in between the right and left thalamus. The anterior surface contains numerous protrusions or recesses, some of which are seen in this image. The infundibular recess, which is located above the optic stalk, the supraoptic recess, which is above the optic chiasm, the anterior recess, pineal recess, and suprapineal recess. The 4th ventricle receives cerebrospinal fluid from the 3rd ventricle via the cerebral aqueduct, which is here. It lies within the brainstem at the junction between the pons and medulla oblongata. And from the 4th ventricle, the fluid drains into 2 places, which are the central spinal cord canal and the subarachnoid cisterns. So jumping straight into the different type of diversion procedures, we could broadly classify them into temporary, which includes the external ventricular drain, and permanent, which includes the ventriculoperitoneal shunt, the ventriculoatrial shunt, ventricular pleural shunt, and endoscopic 3rd ventriculostomy. Beginning with the external ventricular drainage. It was first described for the first time by a French surgeon named Claude Nicolas in 1744. It is often considered a life-saving temporary solution for instances of acute hydrocephalus, of which some pathologies include subarachnoid hemorrhage, intraparenchymal hemorrhage, infections, brain tumors, and shunt failure causing hydrocephalus. Of note, the Brain Trauma Foundation guidelines for the management of severe traumatic brain injury included and recognized that the external ventricular drain is a surgical treatment and for monitoring intracranial pressure. The fluid pressure with this device must be greater than the weight of the cerebrospinal fluid in the system to ensure that drainage occurs. Just to note, the cerebral perfusion pressure is the intracranial pressure subtracted from the mean arterial pressure and can be calculated from data obtained from the external ventricular device, together with the systemic blood pressure. In terms of the surgical technique, Several different entry points and trajectories have been proposed. Dandy's and Keen's points are two different techniques that aim to place the entry point into a more posterior and peritrigonal fashion. But these are likely to cause visual pathway damage, so they are not routinely performed anymore. Frazier's technique requires an occipital parietal trajectory and is usually recommended for pediatric patients or in cases of emergency posterior fossa procedures. Common sites for ventricular catheterization are one, the occipital parietal region, and here we will talk a little bit more about Frazier's point. So at this site, the catheterization is done prophylactically for acute hydrocephalus secondary to posterior cranial fossa lesions that result in swelling post-op. It is located about 3 to 4 centimeters from the midline and 6 to 7 centimeters above the inion. 2, the parietal boss region is another entry site for the external ventricular catheterization. 3, following the point from the mid-pupillary line, parallel to the sagittal suture until it intersects a line extending posteriorly from the top of the pinna. And 4, 3 cm above and 3 cm posterior to the top of the pinna. The trajectory for the external ventricular drain. So we insert the catheter parallel to the skull base, aiming for the middle of the forehead. However, if this cannot be done, then you try to aim for the ipsilateral medial canthus. In terms of how much you are going to be pushing in, ideally, the tip should be just anterior to the foramen of Monroe in the frontal horn. The intracranial length should be about 2/3 of the length of the skull, and the stylet is used for the initial 6 cm of insertion, then removed, and the remaining length is inserted. So it needs to be short enough to prevent penetration of the frontal brain parenchyma, but long enough to ensure that the tip is actually beyond the foramen of Monroe. And this helps prevent the catheter from ending up in the temporal horn, where the choroid plexus is located. And if it is there, then the chance of obstruction increases. In adults without macrocrania, the inserted length is about 12 centimeters when the borehole is in line with the axis of the lateral ventricle. And in infants with hydrocephalus, usually about 7 to 8 centimeters is required. Keen's point is about 2.5 to 3 cm posterior and 2.5 to 3 cm superior to the pinna, and is another entry site that can be used. Brief description of Dandy's point, 2 centimeters from the midline and 3 centimeters above the inion. And as previously mentioned, this point can lead to visual pathway damage or injury. Cocker's point places the catheter in the frontal horn, and the right side is usually commonly employed for intracranial pressure monitors. This procedure is easy, quick, has a short learning curve. The entry side for Cocker's point is 2 to 3 centimeters lateral to the midline, which is approximately the mid-pupillary line with a forward gaze. And this is to avoid the sagittal sinus. And we are also going 1 to 2 cm anterior to the coronal suture to avoid the motor strip. The incision is oriented in the sagittal plane, and the periosteum is elevated. A self-retaining retractor is placed, and a twist drill hole is done. Bone wax can be used to achieve hemostasis. The dura is cauterized and incised in a cruciate fashion. The edges can be cauterized to achieve hemostasis and for better exposure. And then the pia and arachnoid is incised. The trajectory of the catheter is directed toward the medial canthus on the coronal plane. and about 1 centimeters anterior to the tragus on the sagittal plane. The catheter is advanced in a perpendicular manner to the brain surface for about 5 to 7 centimeters, so that the tip can be placed at the foramen of Monroe. The drain is tunneled under the glia and connected to the external drainage system. Of note, there are intraoperative entry points for the external ventricular drainage as well, one of which include Payne's Point. There's also Kearns Point and Parks Point. Briefly, a description of Payne's Point is that it is about 2.5 centimeters superior from the floor of the anterior cranial fossa and 2.5 centimeters anterior to the Sylvian fissure. This provides an approach to the frontal horn of the lateral ventricle. In this image, there are also distances for the different intraoperative points that can be used with respect to the anterior cranial fossa and the Sylvian fissure. Complications associated with the external ventricular drain. Of course, there's a high risk of infection, which can progress to ventriculitis or cerebritis. There's an incidence of up to 27%, but this is primarily related to how long the device is in place. We must be aware that any type of manipulation and accessing of the drainage tubing can be a source of contamination, and of course, it can become accidentally disconnected. So every effort should be made to maintain the sterility of the catheter. If disconnected, it is recommended that a new sterile tubing should be obtained and reconnected, and occlusive dressings placed to cover the incisions. Data from a meta-analysis proved that continuous drainage using the EVD is a risk factor for infection. And in 2015, another meta-analysis of studies on the incidence of infections following external ventricular drainage placement was published, revealing that the overall incidence of infection was 10.6 out of 1,000 catheter days, and showed that in patients with the EVD in place for less than a week, the incidence was approximately 19.6 per 1,000 catheter days, compared to the incidence of 8 per 1,000 catheter days when it was in place for more than 10 days. Blockage of the external ventricular drainage requires rapid replacement to avoid acute hydrocephalus, and a major incidence of failure has been related to the continuous drain approach. Can we use prophylactic antibiotic use to prevent infections associated with this device? So, infections are developed in patients with EVDs who receive prolonged or broad-spectrum antibiotic prophylaxis are often caused by more virulent microorganisms such as Candida and gram-negative organisms. The guidelines for the management of severe traumatic brain injury does not recommend antibiotic prophylaxis for the placement or catheterization of an external ventricular drainage. However, antibiotic impregnated catheters with rifampin have been shown to significantly reduce bacterial adhesion. And the overall rate was 3.6%, rate of infection was 3.6% in a study with antimicrobial impregnated catheters insertion, as opposed to a 13.7% in a standard catheter group, which shows that there is some level of improvement and decrease in infections associated with the antibiotic impregnated catheter. Another complication, hemorrhage and catheter misplacement, with a reported incidence of up to 12%. The factors affecting hemorrhagic complications include the use of oral anticoagulants or antiplatelet therapy, and brain edema and midline shift would be main risk factors for misplacement of the EVD. With respect to the leveling of the device, the drip chamber must be maintained at the prescribed 0 reference and pressure levels, level 0 being to the triggers of the air. Raising the level of the bed could result in a large increase in the drainage of cerebrospinal fluid. The device must be clamped if the patient needs a procedure or needs moving, and it can be clamped if it is the patient needs repositioning, is experiencing vomiting, coughing, or needs suctioning as well. So this image shows that the 0 level is to the triggers of the air, and it shows that the proximal stopcock with the adapter is here, ensuring connection to the rest of the line. Moving on to endoscopic third ventriculostomy and choroid plexus coagulation. So we're moving on to the permanent procedures now for CSF diversion. The endoscopic third ventriculostomy is a minimally invasive procedure where a surgical defect is made in the floor of the third ventricle, and this allows drainage into the interpeduncular cistern. It was first introduced in the early 1900s by Walter Dandy, who performed a choroid plexectomy for the treatment of a non-communicating hydrocephalus in an infant. However, interestingly, the first endoscopic third ventriculostomy was performed by a urologist in 1923 using a ureteroscope. This was done for an infant with acute hydrocephalus. Since then, numerous advancements and improvements in technology and equipment have been achieved. Indications for an endoscopic third ventriculostomy include obstructive hydrocephalus, where a shunt is blocked or infected and the hardware needs to be removed due to repeated infections. For hydrocephalus secondary to posterior fossa tumors, and in this case, you could actually do a one-step procedure to include biopsy of the tumor as well. Of note, case reports of germinoma recurring along the tract of the ventricular scope have been reported in about 13 patients who had tectal plate gliomas in a study done by Whelan et al., who underwent endoscopic third ventriculostomy with symptoms resolved at 31 months. Other indications include subdural hematomas formed after shunting and intraventricular hematomas, for slit ventricle syndrome, for hydrocephalus secondary to aqueductal stenosis, which is the most common indication, for hydrocephalus secondary to cerebellar infarct, and for Dandy-Walker malformation. So in this table, we're talking about the success score of the endoscopic third ventriculostomy. And this was put forward by Kulkarni et al. This is a simplified score which helps us given a prediction for a 6-month success rate for the ETV for a person, for a child with hydrocephalus. And it is based on the child's age, the etiology of the hydrocephalus, and whether or not they had a previous shunt. So in this paper by Kulkarni et al., they assessed the clinical utility of the success score by determining whether long-term survival outcomes for the endoscopic third ventriculostomy versus a shunt insertion were different for different strata, that is low, moderate, and high scores. The high success rate, being more than 75%, was associated with congenital and acquired aqueductal stenosis and tumor obstructing cerebrospinal fluid flow. Intermediate success rates between 50 to 75% were associated with previously shunted myelomeningocele, congenital aqueductal stenosis, arachnoid cyst or Dandy-Walker malformations, and recurrent shunt infections or malformation. Low success rates were associated with post-hemorrhagic hydrocephalus and post-infectious hydrocephalus. So just to remember, the highest rate is associated with acquired aqueductal stenosis, not congenital aqueductal stenosis. I made an error just now. Sorry about that. It has been mentioned that low success rates in infants, low success rates associated pre-existing pathology such as tumors, shunts, previous subarachnoid hemorrhage, as well as previous whole brain radiation and significant adhesions visible when actually perforating the floor of the third ventricle as well, have been associated with low success rates. I included a screenshot of the abstract from Kulkarni's paper, where he did a study on endoscopic third ventriculostomy versus CSF shunt in the treatment of hydrocephalus in children. And the conclusion basically stated that the relative risk for ETV failure was initially higher than that for the shunt, but after a three-month period, the risk became progressively lower. So there's an early high-risk period of failure, but afterward, a patient could experience a long-term treatment survival advantage compared with a shunt. Careful patient selection is crucial to the success for endoscopic third ventriculostomy. There are favorable clinical features as well as favorable radiographic features on CT scan. Favorable clinical features include the cause of hydrocephalus being in the high or intermediate success group, the patient being more than 6 months at age of the diagnosis of hydrocephalus, more than 6 months at the time of procedure, having no prior radiation therapy, no history of hemorrhage or meningitis, but being previously shunted. Favorable radiographic features include clear evidence of ventricular non-communication on CT scan, if there's an obstructive pattern of hydrocephalus, if there's aqueductal anatomic obstruction, lack of aqueductal flow void on T2 weighted MRI, favorable third ventricular anatomy, if the width and foramen of Monro is sufficient to accommodate the endoscope. It is favorable with a rigid endoscope more than 7 millimeters or flexible more than 4 millimeters. If there's a thin floor of the third ventricle, if there's downward bulging floor draped over the clivus, if the basilar is posterior to the mammillary bodies, with absence of structural anomalies impeding the procedure, as well as if there's an AV malformation or tumor obstructing the third ventricular, obscuring the third ventricular floor, with insufficient space between the mammillary bodies, the basilar and the clivus, and with basilar artery ectasia. In terms of the surgical technique, the patient is placed in a supine position with the head in a horseshoe headrest and the neck flexed about 15 to 20 degrees. A linear incision is made around a 0.2 to 3 cm off the midline to the right, and 1 centimeter in front of the palpated coronal suture. A borehole is placed over the right coronal suture along the mid-pupillary line. Optimal position is determined from the pre-op imaging, but the borehole can be placed more anteriorly if needed to provide better access to the posterior third ventricle. A flap is raised, the dura is opened in a cruciate fashion, the pile surface is coagulated and incised, and the needle is inserted into the right frontal horn and directed towards the foramen of Monro. At this point, some fluid can be taken for sampling, and intracranial pressure testing can also be performed. The endoscopic sheet or cannula is inserted into the lateral ventricle, and the foramen of Monro is located by identification of the choroid plexus and septal and thalamostriate veins, as seen in this image. After passing through the foramen of Monro, the optic chiasm, infundibulum, mammillary bodies, the massa intermedia, and aqueduct can all be observed along the floor of the third ventricle from an anterior to posterior view. A diamond-shaped transparent membrane is seen between the mammillary bodies and the infundibulum. The area of the third ventricular floor between the clivus and the basilar artery is the ideal site for the ventriculostomy. And fenestration is then performed, can be done using a closed blunt biopsy forceps. Dilation is achieved using a number 4 Fogarty balloon catheter, or if using a flexible endoscope by gently stretching at the margins. The best site for third ventriculostomy of note is the center of the hypophysiomammillary triangle. The subarachnoid spaces are inspected for membranes, such as the membrane of Liliequist, which are opened. This membrane must be opened. This membrane extends from the upper border of the dorsum sellae to the anterior edge of the mammillary bodies, as seen in this image. And the scope is removed slowly to inspect for any hemorrhages. Choroid plexus cauterization can be used in combination with endoscopic third ventriculostomy. It is commonly performed using the flexible endoscope via septostomy and is more likely successful in infants over a month old who have hydrocephalus secondary to myelomeningocele, who have hydrocephalus secondary to aqueductal obstruction, and if the cauterization is done for more than 90% of the actual choroid plexus. Failure is more likely in those with post-hemorrhagic hydrocephalus of prematurity and those with prepontine scarring. I inserted a screenshot of an abstract done by Adebayo et al., where he spoke about early outcome of endoscopic third ventriculostomy in combination with the choroid plexus cauterization versus just ventriculoperitoneal shunt as primary treatment of hydrocephalus in children with myelomeningocele. And in his conclusion, he stated that the endoscopic third ventriculostomy, together with the choroid plexus coagulation, actually had similar success rates with ventriculoperitoneal shunts at 6 months with a lower morbidity. So it could be considered a viable alternative when treating patients with myelomeningocele and hydrocephalus. Complications can be categorized in terms of intraoperatively, postoperatively, and delayed. Intraoperatively, patients, there's an incidence of up to 41% with bradycardia. Intraventricular hemorrhage as a result of choroid plexus injury can occur, and there's a 0.05% incidence of basilar artery injury. Postoperatively, the patient could have hypothalamic dysfunction, which could actually lead to dysphagia. They could have pneumocephalus, which is commonly seen, subdural hygroma, and hematomas, infection, CSF leak, midbrain injury, and memory dysfunction. And delayed complications include seizures and late failure of the ventriculostomy. We'll move on to ventriculoperitoneal shunt now. So, in essence, a shunt consists of a ventricular catheter, a valve, which is required to maintain one-way flow and prevent reflux, and a distal catheter to divert the fluid from the ventricle to another site that is capable of absorbing the extra fluid load. Of note, neonates and young infants with open fontanelles have relatively low intracranial pressure compared to patients with closed fontanelle. So we have to be aware that the valve inserted should allow drainage at lower pressures. And we'll talk a little bit more briefly in terms of the different types of valves in a little bit. The most common locations for distal catheter insertion include the peritoneum, the pleura, and the right atrium. Indications or examples of disorders associated with hydrocephalus for which ventriculoperitoneal shunts are useful include congenital hydrocephalus secondary to aqueductal stenosis, tumors leading to cerebrospinal fluid blockage of the lateral ventricles, third ventricle, and those in the posterior fossa blocking the cerebral aqueduct of fourth ventricle. For communicating hydrocephalus secondary to meningitis or subarachnoid hemorrhage, for myelomeningocele, craniosynostosis, Dandy-Walker syndrome, arachnoid cysts, idiopathic intracranial hypertension, and normal pressure hydrocephalus. Absolute contraindications to DVP shunts include infection over the entry site, infection of the cerebrospinal fluid, allergy to any of the catheter components such as silicone, and relative contraindications include altered coagulation function, a high CSF protein, and CSF with blood. Pre-op assessment is required. A past history of shunt placement must be known. We must find out if there was any difficulties intraoperatively, if there's any redundant shunt left in situ. If the patient had any history of bowel surgery that may predispose them to peritoneal adhesions. The site of insertion must be inspected for both the ventricular and peritoneal catheters, and the proposed peritoneal catheter trajectory must be determined. The site of previous incisions must be observed to avoid tunneling under scarred tissue, which will make this procedure more difficult. And the skin thickness and the presence of other devices such as CVP lines, gastrostomies, Mitrofanoff procedures that have been done, and pacemakers must be known and located and avoided. In terms of the surgical technique, of course, this is done in an aseptic technique. The borehole is performed at any desired entry point that was previously mentioned, and the dura incised. The small entry point in the cortex is coagulated and incised. The ventricular catheter is introduced into the ventricle and cut to the appropriate pre-measured length. At this point in time, samples can be collected for the cerebrospinal fluid. The ventricular shunt is connected to the valve and secured with a silk tie. Moving on to the abdomen, an incision is made to gain access into the peritoneal cavity. And the site, of course, depends on the surgeon's preference, whether there are any other procedures, as previously mentioned, such as a Mitrofanoff, if the patient have any lines in place, and can be done in the upper quadrant or the midline. The shunt passer is used to pass the peritoneal distal catheter between both incisions, and the peritoneal catheter is connected to the valve and secured with a silk tie. After good distal CSF flow at the peritoneal catheter, it is introduced into the peritoneal cavity. The wounds are then closed in anatomical layers, and CSF sample can be sent to the lab for further testing. In terms of ventricular shunt complications, it depends on hardware issues, patient factors, surgical environment, and technique done. Valves can be broadly categorized into pressure-regulated systems and flow-regulated systems. The pressure-regulated valves are either open or closed to CSF flow, depending on the pressure across them. And there are 4 design categories: slit valves, mitral valves, diaphragm valves, and metallic spring ball valves. The pressure at which the valves open is termed the opening pressure, and that is fixed. There are low, medium, and high designations, which generally corresponds to 5, 10, and 15 centimeters per water pressure, respectively. Does the chosen valve affect the patient outcome? So a valveless shunt with the diameter of tubing, with the same diameter of the tubing, can actually lead to siphoning and intracranial hypotension associated with risk of subdural hematomas. There is the Hagen-Purcell equation, which states that the flow through a tube is inversely proportional to the radius of the tube, the length of the tubing, and the viscosity of the fluid. So, therefore, using a valveless system with a small internal diameter of tubing and a longer length of the tube itself could actually act as a flow control system to help in preventing over-drainage. And this is a similar mechanism by which a flow-regulated valve prevents over-drainage. The incidence of slit ventricle syndrome is lower in patients who have had a flow control valve inserted compared to pressure valves. However, no evidence have been shown that the shunt obstruction rate is related to whether a flow or pressure controlled system is actually used. Some complications of VP shunts include blockages, which is usually made on clinical evaluation combined with imaging. Clinical history may reveal symptoms suggestive of a raised intracranial pressure, and fluid around the ventricular site on imaging is indicative of proximal shunt blockage and or disconnection of the shunt apparatus. Fluid around the distal catheter and or ascites is indicative of a malabsorption process. Infection is another common complication. The most common organisms infecting shunts are Staphylococcus epidermidis infections and Staph aureus. The patient may present with meningitis, they may have peritonitis, or they may even develop a pseudocyst. Shunt removal is the management for these patients in combination with interval antibiotic treatment together with an external ventricular drainage system. And this carries the highest shunt infection cure rate, this regime, and the lowest mortality rate as well, as opposed to removal of the shunt with immediate replacement or antibiotic treatment alone. Shunt overdrainage is another complication as a result of valve dysfunction or selection of a valve that may be inappropriate for the patient. The patient may complain of postural headache and fatigue, may also have an associated subdural hematoma. The treatment for this is increasing the pressure of the valve and draining of the subdural hematoma. Slit ventricle system is another complication which is caused by chronic CSF overdrainage, which actually leads to small ventricle size. It is associated with symptoms of intermittent shunt blockage that eventually leads to non-compliant ventricle. Intracranial pressure monitoring is important in diagnosis for potential shunt malfunction. And of course, the treatment for this is revision of the shunt. Moving on to ventriculopleural shunts. This is an alternative to ventriculoperitoneal shunts if the peritoneum cannot be accessed easily. Contraindications include having previous chest surgery leading to adhesions, if the patient has active pulmonary disease, including a large amount of pleural effusion, and if there's borderline lung, if the patient have a borderline lung function. The surgical technique, the pleural space is entered along the anterior axillary line between the fourth and sixth intercostal space, and it is inserted using a muscle splitting approach along the upper border of the rib to avoid the neurovascular bundle. The pleura would be seen and it is opened. The catheter is gently introduced into the cavity away from the lung parenchyma. The patient must be monitored with serial X-rays, SpO2 monitoring, and clinically for signs and symptoms of respiratory distress. If the fluid progressively accumulates, it could lead to respiratory distress with significant shift of the mediastinum, and percutaneous drainage of the fluid is the treatment, together with accessing another site for detubing. Ventriculoatrial shunts shunts ventricles through the jugular vein to the superior vena cava, and the catheter tip is placed within the right cardiac atrium at the T6 level. The atrial catheters have a slit valve that actually prevents the reflux of blood up the tubing. A shorter tubing results in lower distal pressure and less siphon effect than the ventriculoperitoneal shunt. However, the pulsatile pressures associated may alter the CSF hydrodynamics. It is a treatment of choice when there are abdominal abnormalities present, such as peritonitis, if the patient had extensive abdominal surgery, if they are morbidly obese, and for premature infants who have had necrotizing enterocolitis that may lead to adhesions. The patient is placed in a supine position with the head slightly down to avoid air embolus. And of note, they must be connected to an ECG machine as ventricular ectopic beats can be encountered. It can be done via an open procedure or percutaneous procedure. For the open procedure, right-sided neck incision is made to expose the common facial vein, which is tied proximally and held with a stay suture distal to the venotomy site. A needle of 20 to 22 gauge is used to puncture about 3 centimeters above the clavicle between the heads of the sternocleidomastoid. The catheter is then advanced down the jugular vein into the superior vena cava and confirmed by fluoroscopy, the final position. With the percutaneous procedure, the subclavian vein is cannulated using ultrasound guidance, and a Seldinger wires pass into the vein, into the right atrium. A dilator expands the entrance to the subclavian vein, and a peel-away ventricular catheter is inserted. Again, fluoroscopic guidance can be used to confirm the tip of the catheter being positioned in the right atrium. The atrial catheter is then connected with a straight connector to the distal catheter, and the wound is closed in layers. Some complications associated with ventricular atrial shunts include shunt-induced immune complex glomerulonephritis, which responds to externalization of the shunt and appropriate antibiotic therapy. Pulmonary hypertension due to microemboli, infective endocarditis, wound infection with an incidence of 5 to 8%, the patient actually outgrowing the shunt, ECG instability as previously mentioned, shunt malfunction, which is up to 40% incidence in the first 2 years after insertion or revision, and rarely superior vena cava thrombosis. Other ventricular shunt sites that are not used anymore include the gallbladder, which had a 63% success rate. It wasn't approved or commonly used because the gallbladder have a low capacity of 30 to 60 mils, and there's only an absorption of up to 1,500 mils per day. It led to complications including bilious peritonitis from bile leakage due to disconnection. Postprandial elevation of intracranial pressure have also been reported. Other sites included the ureter and bladder. However, this was associated with a lot of electrolyte imbalances due to losses in the urine. Briefly mention the lumboperitoneal shunt, which is a closed sterile system to allow drainage from the subarachnoid space. The drain is inserted via a specialized spinal needle into the subarachnoid space at the L2, L3 level, as seen in the picture, or below, and it will be alongside the cauda equina. It is indicated for postoperative or traumatic dural fistula or CSF leak in the treatment of shunt infections where the ventriculopleural or atrial shunts cannot be done, in the diagnosis of idiopathic normal pressure hydrocephalus, to reduce intracranial pressure during a craniotomy, as adjuvant therapy in the management of traumatic brain injury, to improve spinal cord perfusion for thoracoabdominal aneurysm. It can be indicated to help with non-traumatic subarachnoid hemorrhage and increased intracranial pressure associated with meningitis. In terms of the surgical technique, the patient is positioned in a lateral decubitus position with knees flexed. A 1 centimeter incision is made at the L4, L5, or L5S1 level, and dissection down to fascia overlying the spinous processes. The table can be tilted to 30 degrees reverse Trendelenburg to expand the lumbar subarachnoid space and make the procedure easier. A 14 gauge 2E needle is inserted into the subarachnoid space and oriented medially so that the tip penetrates the dura in line with its longitudinal fibers. The needle is rotated so that the opening is directed rostrally. and CSF flow is visualized. The stylet is then removed and the shunt tubing inserted for a total of 17 centimeters. The TUI needle is then withdrawn until the tip is out of the tissue. While the needle is being withdrawn, about 9 centimeters of tubing actually is withdrawn together with the needle, which is why we insert it for a length of about 17 centimeters. So about 9 centimeters of the catheter accompanies that withdrawal, so that the remaining catheter inside is about 8 centimeters. Then a flank incision is made and a tunnel passed from the flank to the back incision. The catheters then pass from the back incision to the flank through the tunneler. And placement is done within the abdomen via an open placement into the peritoneum or using a choker. The catheter is feeded from the flank to the peritoneum after CSF flow is visualized and it is secured. And it can also be secured to the subcutaneous tissue using a retaining sleeve. The transducer on the setup is level to the patient's shoulder or iliac crest as shown in this image. The pressure level indicator is located on the drip chamber, similar to the external ventricular drainage system, and is aligned to the level at which it drains the order of volume. Complications include difficult access to the proximal end if revision is needed or assessment of patency needs to be done. Leakage of cerebrospinal fluid around the chamber, risk of arachnoiditis and adhesions. In obese people, the peritoneal catheter may gradually spontaneously withdraw and coil into the subcutaneous tissue. And lastly, infection causing meningitis. These are my references. Thank you for your attention.